Good afternoon, everybody. It's 1:30. Welcome to the December Primary Care Commissioning Committee for Norfolk and Waveney CCG. This is a meeting in public, so we are being live streamed currently. I just want to remind everybody to turn off their mics when they are not speaking, just to reduce interference. And I'll be grateful if you put your camera on so I can see people rather than a blank screen and talking to myself. It just makes my life slightly easier. And if you want to speak, either use the hands up function on the WebEx or put your hand up and wave frantically at me, and I will try my hardest to spot you. And if I don't, I'm sure somebody will tell me. So for the start of this afternoon, the first item is just to report I've taken a chair's action in relation to supporting the general practice in Norfolk and Waveney as part of the NHSE programme, and included in your pack is the details about the funding that has been made available to primary care. For apologies this afternoon, we've got from Kathy Branson, Bill Burrett, John Webster, Jill Jones, from the LMC, Kath Byford, Mark Burgess, and Tony Goldson, who might join us partway through the meeting as well. Moving on to declarations of interest, just for those who are eagle-eyed, the declaration of interest is going to be updated for the January meeting, because there's some inconsistency between some people have got their GP practice listed and others haven't. And this will come to the January meeting. And if you've got any other declarations of interest that need updating, please let the CCG know. And are there any declarations of interest for this afternoon's agenda item? Karen? You're on mute.
I'm trying to do both systems, by telephone and, for example, we're recruiting a volunteer workforce to help around the vaccination programme as well. So I think it's a valid question. We probably will need a bit of time to work through things a bit more and to understand the logistics around how the vaccination programme will work, which is, you know, officially over 7 days a week rather than business as usual over 5 days a week. So
just very conscious, Parveen, that within the breakdown, safety domain is rated as inadequate and red. So have we got assurance as a committee that actually that the key safety concerns have been addressed as the first requirements, I suppose? So are there any ongoing concerns there in respect to safety?
The safety alerts, safeguarding were two of the main areas that they picked up, and those had tight timescales around improvement in the north. What we would like to think, we probably need to park it until the COVID vaccine situation is out of the way.
Okay, thank you.
Michael?
Yeah, certainly in terms of prescribing, we've got prescribing leads meetings going back up and running, although we've paused them till February now. But the first agenda item is drug safety alerts, and we talk about what CQC have recently picked up at other practices and things that CQC are likely to ask you based on the safety alerts. So we're giving them a really high profile and talking about other things that are picked up at other practices. So we're sharing certainly those and encouraging practices to take it quite seriously, which would be good.
Thank you for that. Jason?
Right, just a really quick one. Was this a targeted inspection or routine inspection?
No, it was a target inspection due because of a number of prescribing errors made in the care home.
If there are no other questions, I will move on to the next item.
Thank you.
Thanks a lot for that, Parveen. The next one is on that there's a couple of papers on Norwich business case for PMS funding. who's taking the papers?
I think Emma Budd was planning to attend. I'll just chase her, Doris.
That's okay. Sorry, I'm just a bit ahead of time.
Doris, do you want James and I to leave now, go out and come back in again?
No, you can stay in, but I probably won't call you for comments.
There was one comment I wanted to make about the LMC submission. I don't know if I'm allowed to do that.
No, I would rather you didn't. Thank you.
Okay, all right. I shall disappear.
Do you want to swap around the order and do the asthma one first? Is Michael taking that?
I think they are both for Emma.
Oh, are they? Okay. I was trying to be.
I have chased her. I'm just looking further on, but
Why don't we do the workforce? Pavine, sorry.
Sorry, I didn't realise I was still on mute.
Whether you were trying to talk to us or
I've just realised I'm still on mute. No, I was just going to say, do you want me to cover the resilience paper whilst we're waiting?
okay. Shall we do the primary care resilience programme, and then we can come back to the other two when they join us? Pavine?
Okay. Thank you, Doris. So I'll take the paper as read. So we get regional funding for a resilience programme. Last year we were allocated 157k, and a majority of that went to where we found practices that were most of sustainability and resilience risk, and that was the beaches. This year we've been allocated 154k, and as part of the submission in terms of the papers, the criteria is set nationally, but we can put some local indicators in and weighting. So this year, because we have a number of practices that have resilience issues, particularly in terms of their CQC rating and turnaround, we've given the highest weighting to that particular category, as well as some additional criteria around resilience. So that went out to practices in early November, and there's a closing date of the 4th of January for applications, and so practices can submit against that particular criteria, and then we'll shortlist on the 4th of January, along with LMC and NHS England and CCG colleagues, around who gets a share of that particular funding. But we are expecting practices that probably currently are at high risk of under requires improvement or special conditions, potentially to get the majority of that funding. But until we get the applications, we can't say for certainty. Again, happy to take questions.
Are there any questions for Pavine on the primary care resilience funding paper? I think it's on page 74 of the pack. No. I was just I was just a bit surprised the outcome wasn't weighted. But is that because it's difficult to measure?
A bit of both, and I think also we couldn't get a consensus with our LMC colleagues around keeping it consistent, so we decided to leave that out, because we knew from the weighting that we've given to some of the individual questions that will really draw out the ones that actually desperately need the funding, and we'll be measuring those anyway because they'll be under improvement plans.
Right. So the way the weighting is working is actually the practices that are struggling are likely to get a higher weighting than those who are not.
Yeah.
Okay. Thank you. Any other questions on this paper? No.
Thank you.
Great. Has Emma joined us? I'm just trying to look down my list.
We've had Jade join us for
Ah,
this item, Doris.
brilliant. So we can go back to the Norwich paper, which is on page 36, I think.
Yes, thank you. So the first one that we're talking about is the asthma pilot project. So I assume that the paper has been read. I just wanted to highlight a couple of key points. So the request is to fund a 12-month project pilot for a prescribing nurse for £76,566. So this 12-month pilot is to enable ongoing assessment and commitment for a permanent solution. In the paper, it refers about the aims. I wanted to just really highlight a couple of key points. The project is to improve the overall well-being of the child, obviously help with asthma reviews within the QOF requirements, reducing unplanned GP and out of hours A&E attendance, that's one of the key elements, but also educating and working with families and their children, and importance about attending reviews, also looking at a holistic approach across primary care and community organisations, and particularly with parents and children in the younger group. So it's been worked in collaboration with a number of system partners, and I'm happy to answer any questions. But in summary, for Norwich in specifically, it's approximated about just under 3,000 children aged between 15 and 16 have a diagnosis of asthma. And we've also highlighted in Appendix 4 the A&E emergency admissions in relation to our Norwich community as well. And then looking at also, we're estimating at this stage just under 2,000 have been do not have asthma diagnosis, but actually they have an inhaler. So we really wanted to work with the schools that have been identified initially, but with the view of rolling out across the PCM as the project model opens up.
Thanks, Jade. Are there any questions for Jade? Hein?
Thank you, Chair. Several questions, so I'll be selective. One is a practical one. So the pilot is at a junior school, and if I read it correctly, one of the selection criteria is that the child needs to be registered at a Norwich GP practice, but Wenson might well have children from outside Norwich, so that comes across as a bit harsh. So that's one question. Is it really, as I read? The second one is, if this is a success, what happens after 12 months? Where are you going to secure funds to sort of continue this? Those are my questions.
Thank you. Yeah, absolutely. So it is a test pilot model. As I said, we have worked with a number of system partners. So I guess the opportunity is there from a system-wide approach, so particularly with children and young people. So yes, it initially could be piloted within Norwich, but proven successful, it might be a system-wide initiative, because we understand this is not happening across the system in Norfolk and Waveney. So this is something that could have the opportunity to be a wider at-scale solution. So that's the first one. You're absolutely right. So in relation to the schools that have been identified, there could be some children registered outside of the Norwich boundary area. But again, we would like to, if the opportunity allows us, to work with other system partners across it to see if that could target a wider concept. But initially it is to trial it within Norwich, proof of concept, and then there could be options past part of the evaluation review to open up further.
Thank you.
Karen?
Thank you, Doris. Struggling with my mute buttons. It's a really good paper, Jade. Thank you very much. But I just wondered how we were going to capture the experience of those youngsters in terms of the benefits and the outcomes that they may have received during this pilot. Because I think it's really important that we might think something is key to a young person, but we need to ask them what's important to them.
Yeah, absolutely. I can feed that back. If obviously the model is approved, then we can ask for that to be built in as part of the evaluation process, working with the children as well as with the schools as part of that test learn concept. So yes, I can make note of that and feed that back to the PCN team in One Norwich.
Thank you so much, Jay. Cheers.
I was just wondering how you came down to selecting the particular school for the pilot. Were they self-selecting group, or was it based on sort of A&E attendance data? Or
initially, the school actually approached the Norwich PCN, so that's how the concept came to us. We were working in collaboration with the school, so they are that particular school plus another, but there are some students within a cohort that are working with the James Paget, and that's one of the clinicians will be involved with that, is some of their patients they're being seen, but they go to Wensum College. So that was really a educational awareness event, and then this led on from those discussions as part of our engagement with communities.
Okay. John, did you want to come in?
Yeah, thank you. Just to repeat, I think it's a really helpful paper, so thank you, and certainly supportive of it, and recognise the impact on health inequalities, particularly starting in the Wensum area of Norwich. My question is, I suppose, linked to Heinz in a way about potential after the year, and it, as a non-clinician, reading it seems to suggest it's about supporting children with their inhaler technique, and then after that, is that child then kind of sorted as such, or therefore can the practitioners move on to different caseload of patients, or actually is it a growing and growing caseload? So actually there could be a larger uptake needed at the end of the pilot. Does that make sense?
No, it does. Obviously, linking back to health inequalities for the PCN, like any PCN, the Impact Investment Fund are the funding streams that could be utilised to help support it long term. Obviously, depending on if it's successful or not. But yeah, you're absolutely right. Making sure it's financially sustainable. There are obviously different funding pots within the PCN that can be enabled to fill that longer term, but it would really depend on what the evaluation and the outcomes would be to see if that's sustainable going forward. But take your point, John. Yes.
Jason?
Thanks. As there's a 12-month review of this, are the posts anticipated to be recruited on a fixed term? Question one. And question two associated with that is it practical to be able to recruit into posts if it was only a 12-month fixed term for this type of work? I'm not sure.
My understanding, it is what's been proposed is for 12 months. Some of our roles that we have recruited to are based on that sort of concept. But yes, we also have a potential pool of interested candidates subject to this pilot's being selected. So we have got a few candidates already proposed, and they are aware it's a 12-month provision subject to the longer term sustainability of the project.
As a non-clinician, I'm kind of surprised that children's been prescribed with inhalers and they've not had a diagnosis. You know, how does that happen? Oh, Andrew's going to solve the problem.
Do you want me to answer that?
That would be very helpful.
So this is not with a health watch hat on. It's because it's very difficult to make a clear diagnosis of asthma in young children, particularly toddler age. You get an awful lot who get what you could probably call a post-viral wheeze that does respond to inhalers, but that is not the same as making a definitive diagnosis of asthma. So certainly in younger kids, and this is lower than school age, of course, it's very difficult. That's the straight answer.
But I would have thought that there would be a one-off inhaler prescription rather than a recurring.
No, they get it. kids like that tend to get it again and again because they get, maybe a dozen viral infections in the course of a normal year, or certainly over the winter. And the other thing, of course, it's all very closely related to social deprivation, and therefore lack of follow-up and non-attendance at review clinics, which is I'd probably guess, part of the issue of saying, well, let's put the nurse into the school rather than expecting the children to come to the surgery or the nurse, which is a great thing to do if it's workable.
Thank you. Are there any other questions for Jade? No. Michael?
Yeah, just one comment. I mean, I think it's a really good idea for a pilot. Clearly, we should question diagnosis in some of these kids for the reasons just pointed out. But inhaler technique in children is extremely poor on the whole, and anything that, if patients actually need the inhalers to get the full effect and prevent emergency admissions and morbidity would be a great thing, and we could hopefully learn from it and spread it in maybe this model or a different model, depending on the findings. So I'm just adding some words of support.
I think inhaler techniques is poor in adults as well.
Oh yes, but catch them younger. Yes.
But anyway, let's not go off the point. Are the voting members happy to support the proposal as set out in the papers? Yep. That's so you've got the nod for that one. The LMC did make some comments offline that we have been copied into, and no doubt the officers will respond accordingly.
Yes, we've got those. So yeah, Norwich, Emma Bug will be formally responding back to the LMC based on the queries. Yeah.
That's great, thank you. Moving on to the opiate reduction service.
Thank you. So yes, so this is the other paper. So it's a 12-month pilot looking at a nurse prescriber for 62,000. So it is a nurse prescriber dedicated resource for 1 year, with the provision of working with the opioid reduction service within Norwich PCM. This pilot will be supported by the Drug and Alcohol Liaison Team at the NNN to ensure sustainable pathways of re-availment with our cohort of patients. We have obviously worked very closely with a number of stakeholders to understand different concepts that are already in pilot within Norfolk and Waveney, for example, with obviously the one of the pilots within Great Yarmouth and Waveney. So just really wanted to highlight that it is embedding a collaborative approach within our acute and our primary care sectors to deliver an integrated care holistic approach. Again, we're working with a number of system partners. It is to benefit the whole of Norwich PCM. You will see in the information that from a system perspective, Norwich is the lowest in opioid reduction, but obviously there are clear pockets that there could be improvement made. But equally, Norwich PCN has the highest death rate with opioid reduction, obviously within Norfolk and Waveney, but the third in the UK. So that's what we're looking to put this pilot into to address those inequalities.
Thank you. Are there any questions on the paper? John?
Two questions, if I may. One is I'm just interested in Michael's views with his Great Yarmouth and Waveney experience and his sense of the proposal. I'm sure he'll comment. The other one is just getting a proper understanding, I suppose. Is the proposal for the nurse to actually do the treatment almost in isolation and support patients, or is the ethos about this to support and train up people within practices so that actually at the end of the year it's a sustainable model that doesn't need further support? Because I know one of the risks is about not being able to extend the funding after 12 months. So I suppose the question is how much of the project itself will be about creating a sustainable approach.
Do you want Michael to answer his view first before I go into the sustainability?
Well, yeah, I mean, I'll speak about it. It's certainly we've set up a dependence forming medicines working group across the Norfolk and Waveney, including various partners in SFT, and CGL will be included at the next meeting. They weren't at the first, but they will be. And we're interested in this model. It's not a model we used in Great Yarmouth and Waveney when we reduced from being the highest prescribers of opiates in the country because of deprived coastal area and high activity of chronic pain prescribing locally. We use GPs particularly, and we used an incentive quality scheme for GPs, but we're quite interested in seeing how it works. It's a different model to add to the mix, and provided they work very collaboratively with practices, and I think they do need to train practices and upskill them so that practices have some skin in the game, so to speak, rather than it being an external person who comes in and does things to their patients that they perhaps don't have much buy-in in, I think is quite important. And we'd be interested possibly if early indications are that it works in moving it to West Norfolk, maybe the QE, if possible. So, but we need to see, we need to pilot it and see how it goes, and get the people running it involved in our dependence forming medicine working group, so that we get regular feedback and hopefully tweak the model if that's the appropriate thing to do, or unblock them things with certain practices if they feel they're not engaged with it. So we're quite keen that we try this model because it is an issue. Certainly Norwich opiate deaths has received a lot of attention, particularly around Norwich, but there are other parts of the county which tend to use more opiates. Great Yarmouth and Waveney, we did it without this model, but I think it's an interesting pilot.
Thank you, Michael. Yeah, so to answer your question, John, so yes, it is going to be very much a practice-based initiative with our secondary care sort of providers as well. So it is very much working at a PCN collective response. What we're trying to do is actually share that learning within the practice, so definitely addressing that. So this is a nurse-based role, where previously, as Michael's focused on, highlighted, it was more GP focused. So we've recognised different workforce skills that can be shared across the primary and secondary care. Again, we've got some key partners within that, but it's really going to be addressing the lack of psychosocial and addiction input into this patient group. So it's very good, obviously looking at the actual pharmaceutical element, but we really want to focus in and hone in the emotional support in the cope of reducing opioids. So this is where that is slightly different from the model that's been across the system. So it's looking and addressing those psychosocial addiction input as part of the role.
Sodhi?
One of the things that worked well, I think, in Great Yarmouth and Waveney was the introduction of, as part of the quality scheme that Michael referred to, so that groups of practices would develop a policy around drug-seeking behaviour, and having a joined-up approach to drug-seeking behaviour, because there was undoubtedly some movement of people between practices when practices started focusing on this, and I would imagine, therefore, that something similar might happen when this scheme is implemented, if it's approved today. So is that something that Norwich PCN is thinking of as a whole, and how will practices kind of join together? As Michael said, it's really important to have the practices working really closely with this scheme.
Yeah, absolutely, Sadie. Yes, so the model will be based on an all-party sort of group for obviously looking at prescribed drug dependencies, but actually the withdrawal support that is required to help obviously address the tackle of and the risk of opioid dependency through early intervention and prevention going forward. So yes, that's very much some of the considerations is working across the Norwich PCN for that collaborative working approach. We've definitely looked at obviously the Great Yarmouth and Wave model. We've obviously in relation to that going to follow best practice as well as much as we can and embed the learning across the system.
Did you want to come in, Karen?
Thank you very much, Doris. I'm just very interested to know, Jade, in your paper, you said a progress report will be provided in 6 months. Can you tell me the governance around it on a monthly basis as the project rolls out or the pilot rolls out?
Yeah, through the clinical lead, so that would be through Sarah Ambrose, which is our clinical lead within Norwich PCN. She'll be taking the lead within this particular project. So the governance from a clinical perspective will also be administered through her. So we as a PCN, through the CCG, have requested, if subject to this approval, that we get progress reports. And that will come through either through to Emma Bug. We also get monthly reports through Norwich, One Norwich anyway, on all of the projects that have been approved, so we can see the progress. Obviously, do any RAG status risk mitigation if the project's not delivering. So that's part of our normal governance process with all PMS approval papers that goes through Emma. But clinically, that would be Sarah Ambrose from Norwich.
Thank you. And can I just have a further question, which is around any adverse incidents? How will that be reported in live? Clearly, there's the DICE reporting system for primary care, but how will that be flagged in terms of immediate action?
Again, I will need to come back to you on that one. I'll get the answers from that. But my understanding, as said, from a clinical governance overview, that will be through Sarah Ambrose, obviously with the dedicated nurse within the NNN as well as part of that route. Yeah.
Thank
but
you.
I'll get a written confirmation so I can confirm that for you, Karen.
Thank you very much.
Tony?
Thank you, Chair. I'm assuming, and I will take my assumption as correct, that they will be linking into the drug and alcohol teams because they are obviously prescribing opioids and GPs are prescribing it. You nod your head, you know what I've got to ask. Okay, fine, I accept your answer. I know what the answer should be and you've got it. Thank you.
Yes, that's where this is very much in partnership with our secondary care acute providers through the drug and alcohol. So yeah, it's very much a collaborative approach.
Thank you. Are there any other questions? John?
Yeah, so just coming back on the earlier question to some extent, and thank you, Jay, for your response. I suppose it's just, I'm very conscious that we often like to support positively pilots for new things, but then you get to 6, 12 months and time passes and what do we do, and pressure then to continue it. So I think probably in terms of what's been described, if the ethos of this one can be, it is 1 year because it's about upskilling and learning and the sorts of things that Michael talked about, and not an expectation necessarily that it carries on, as opposed to almost a year with a view to building up the case for it to carry on, if that makes sense. I think there's something about setting expectation. Clearly, that's not prejudging the outcome of it, and if the outcome after 6, 9, 12 months is actually, there's a cast iron case for this, well then clearly that case can be made. But I think it's about just making sure the ethos of it is right.
Yeah, absolutely, John. Yeah, that's part of obviously the evaluation process. If it is something that's sustainable in the longer term, as I said, with the impact investment funds through PMS, through the PCN network development funding, that's something that would be considered longer term. It could be an option, obviously with the partnership working as the wider PCN as that grows, making sure all our system partners are integrated within this process. So yeah, I take those comments on board.
Thank you. No other questions? Oh, Hein?
Thank you, Chair. On page 57 of the pack, there's a number of risks highlighted. And the last one is risk of duplication of service provision. I heard Michael Dennis welcoming the pilot. Difficult to assess how much of a potential overlap there is. I'm not sure who's in the best place, Michael or Jay, to comment on that.
So very much we very much link up with Michael and Lois as part of developing this. Obviously our pharmacist team and obviously the pilot will continue to engage. It's supporting the overall Norfolk and Waveney opioid reduction initiative anyway. So we try to avoid the duplication. So that's why we really want the PCN really wanted to understand the Great Yarmouth and Waveney model, how that can be applied, what the differences are, so we avoid that duplication. But overall, to get the same result, maybe in a slightly different way through different workforce skill mix and through a different model. But yes, we'll definitely be sharing all our learning and working with Michael and Lois as part of the Meds Optimisation Project's work.
Okay, thank you.
Michael can also answer anything further.
Yep, Michael.
Yeah, go pick up. Yes, I mean, this is an ongoing piece of work for us to reduce. It's in my paper every month, dependence-forming medicines by a range of means, and hence we set up a dependence-forming medicines working group so that we can join up and understand the different ways that things are handled or historically have worked well in GYW, and things that haven't really changed much in West Norfolk, for instance. And it's important that we try this. There is a little bit of overlap in terms of it's in our prescribing quality scheme that we like practices to look at these, and we monitor it, and we talk to practices at prescribing leads meetings about their performance on dependence-forming medicines. So there's a little bit of overlap, but we're well aware of it. So we're not treading on each other's toes, and hopefully it's synergistic in that respect. And we'll get some early indication whether it's working or not, and tweak the model as necessary. I think is what I've outlined before. But yeah, we're well aware of potential overlap, and that's possibly a good thing to a certain extent. But we'll make sure it's managed.
Yeah, thank you.
Are there any other questions before I? Right, so are the voting members happy to approve this? Tony, sorry. You're on mute.
Sorry, I was raising my hand to approve. Sorry.
Sorry, you're not a voting member.
Oh, I'm not, am I? Oh, damn. Oh.
No, I'm not trying to. It's just always welcome your contribution, but just for the minutes, we need to make sure we're correct. So Hein, John, and myself are happy to approve this. So so both those papers are approved. And again, the LMC had made some observations by email, which somebody will respond to.
Yes, thank you.
Thank you very much.
Thank you.
Thank you. Moving on to the Workforce and Training Hub, I see Claire's joined us.
Good afternoon, Doris. Thank you. Thank you for allowing me to join today's meeting. Have you all had a chance to read the papers at all?
Yes, take it as read. Do you want to highlight anything?
So yeah, it was just for noting really, and to introduce myself. Oh, let me turn my video on, apologies. As a training hub manager, so supporting primary care, primary community care, predominantly the 105 GP practices within Norfolk and Waveney and the workforce within them. So that's circa over 4,000 staff who we support in their workforce and development, their continued professional development, and that's through short courses right through to master's degrees. I continue to work with the University of East Anglia on many of the projects which come through Health Education England. So that might be upskilling a member of clinical nurse to an advanced practitioner. And that goes across the whole multidisciplinary team. So it's not just nurses. We've got a lot of, I think you've heard previously about the additional roles. So we are now working with the universities to ensure that there's advanced practitioners across the whole multidisciplinary team. There's the funding streams that are coming through from NHS England and Health Education England for training. We have to make sure that we are on target, and COVID-19, although has been a concern, we have been embracing the change from the training hub perspective, and programs are still on track within their budgets, and we are meeting our KPIs as set out by our funding bodies. And yeah, we have had to complete many COVID specific training at pace and at scale. So ensuring that the governance and the procurement exercises behind that are still completed when it's required at such pace and scale has proved a challenge, but we seem to overcome it and get on with the due roles that we need to go and programs that we need to get on with to support the workforce, and then making sure they're resilient more than anything, and that it does come back to their health and well-being, and making sure that they are not doing tasks and being responsible for things that they are not competent to complete. So does anybody have any questions about the training hub?
Any questions for Claire? Hein?
Yeah, thank you, Claire. Thank you for the note. Two questions really. One, I may have missed it, but there is a maturity matrix in Appendix 1. I was curious, where does the training hub score itself at the moment? Maybe it may have been in the note, but I couldn't see it. And the second question, maybe for a next update to this committee, would be good to get some sense on how the take-up of the training is, how many people follow courses, etc. It was difficult to see how the take-up is for the 4,000 workforce that you've described, so that's more for future reference.
Yeah, very happy to bring future reporting to the Primary Care Committee, and it is part of the maturity matrix, so it falls very nicely in to what is expected of us. The ambition, our maturity matrix takes us up to March 2021. We are in line, we're working with Health Education England and with our primary care strategic commissioning on infrastructure to support the maturity of the training hub and the programs that are expected from that. And that's still under development. Obviously, there has, because of COVID, sometimes we've had to reevaluate and take priorities, and priorities at the moment are, of course, COVID-19 and the vaccination program specifically at this present moment in time. So yeah, we'll very happily bring reporting to, and I also report monthly to the assurance board, the Workforce and Training Hub Assurance Board, which meets bi-monthly anyway, and I report to Primary Care Networks monthly on, just so we can identify if there's any inequalities or if any practices aren't engaging with the training, or a specific role or workforce is not getting the training they're required to do their jobs. So reception and non-clinical staff are quite key to that at the moment, as they move to more of a care coordinating role. So it's making sure that they are getting the correct training required to do their new role under that title.
Thank you.
Andrew?
Yeah, hello Claire. This is a Health Watch question really. Have you done anything to ascertain or to establish any public involvement with the nature of the training? In other words, what patients and families would like to see their health professionals and other support staff doing?
Yes and no. It's under, and we're very lucky to have just recruited to a training hub fellow. So she is a GP within Norfolk and Waveney, and we are engaging with, and we're trying it as a pilot We hope to trial it as a pilot, and it's being very much supported and wanting by NHS England to engage with the community to see what they want from the workforce within their own practices, within their own community, to make their own health inequalities better and improved. So yeah, that is something that is in discussion as we speak, and meetings are still happening, so it hasn't been rolled out yet. And I certainly need to take it to the primary care strategic commissioning leads. I think Sadie's on the call, and to the assurance board before that is rolled out. But yeah, it's definitely something that we want to do in the future.
Great, thank you. And then perhaps if you'd like to get in touch with Healthwatch as it evolves, we could have some
I
input.
would very much like to have you on board, very much.
Great. Okay, thank you.
And obviously that's sort of both Norfolk and Suffolk Healthwatch for the Waveney part of it as well. So thank you very much. Are there any other questions? Thank you very much for your report, and we look forward to seeing you again soon.
Thank you, Doris. Thank you.
Moving on to the PCN development and locality update from West Norfolk. Rebecca's joining us. Welcome, Rebecca. And
hi, sorry, I struggled to unmute myself then.
So we've got your paper, which we've taken as read. Is there anything you would like to highlight or update us on?
Well, I guess it's the blindingly obvious, really. So obviously when I wrote this paper, it was slightly before COVID vaccinations had really come to town. So obviously I'm more than happy to talk about West Norfolk's approach to that as well, because I'm very aware that's a piece of one of our priorities at the moment that has been omitted from this paper.
Well, do you want to do that before I open up to questions?
Yes, of course. So the practices in West Norfolk are enthusiastic about delivering COVID vaccinations. In terms of where we're at the moment, we have a site that's planned to go live next week. We then have another site, another PCN for it's Fens and Brex PCN that will be in wave 3, so commencing 21st December, and then the other 2 PCNs will commence after Christmas. So we're currently very busy at the moment planning. I think the relevance to PCN development, particularly in West Norfolk, is for those of you that probably know primary care in West Norfolk, in that generally the practices have managed in quite an isolated way. They've come together when they've needed to, but there haven't been any formal working together arrangements. So our PCN development has really formed around the delivery of service specifications and the delivery of services. So I think that's probably something to note, in that whilst obviously the COVID pandemic has caused quite a lot of disruption, it has also forced an awful lot of PCN development and those groups coming together to deliver services around COVID. So that's been a really positive thing. If anything positive can come out of the pandemic, for us it's that.
Thank you very much. Are there any questions for Rebecca? John?
Thanks. Hi, Rebecca.
Hi.
Just interested that clearly lots of good work happening and planned within West Norfolk, but we've been aware for a long time that prescribing is a particular area of outlying activity, if that makes sense. And I'm sure Michael will come on to this as well in his report, but just wondering if that features, it didn't shout at me from the report in terms of it being a particular focus, I suppose, for West Norfolk.
So it is a focus, John. I think it's reflected in the ARRS recruitment. So the biggest group that we're recruiting in West Norfolk is clinical pharmacists. I think Michael will be very pleased to see that and associates. So absolutely, it is a focus. I'm aware that particularly the practices that have been struggling, particularly despite the COVID pandemic, are really working on that. And we actually did have an issue a couple of weeks ago where a patient had queried why they weren't being prescribed something. So whilst we had to deal with that in the round through our patient's complaint team, it was reassuring to know that there is far more focus in those particular practices that have really been struggling. So I think they're busy recruiting at the moment. They have been successful with the staff they've gone out to recruit so far. So I'm really hoping that through that and also our medication reviews, that we can really get on top of some of the issues we have.
Thank you.
Michael?
Yeah, certainly. Yeah, Rebecca. When we had face-to-face local delivery groups, etc., I came along and stood in front of some data just to show West Norfolk is a bit of an outlier. Is probably not as much of an exaggeration as it should be on some of the indicators, and remains at the moment. But certainly, we're engaging with the PCN pharmacists. We've got a meeting with them on Friday actually, and we talk about the priorities. But I think we perhaps do need to engage with the clinical directors because and just show their visibility from space on one or two indicators.
Yeah,
not to put
more
too
than
fine a
happy,
point on it.
Michael.
Yeah, so
Yeah,
by all means, invite
yeah.
me along. I mean, in my paper, I mean, I talk about broad spectrum antibiotics, and the 4 highest prescribers are in West Norfolk, and DFMs. Some of the highest prescribers are in West Norfolk. So something that they need to be repeatedly nudged on, because the pharmacists on their own can't necessarily undo a lot of that. But so please do invite me along if when you feel it's appropriate. I know
I
it's
will do that.
busy time at the moment. I know.
It is, but I think Michael, sharing the data with them, and even if it's on a one-to-one basis, I think that was the most powerful thing before.
Yeah.
So I think it can sometimes, the messages can sometimes get lost in all the messages that are out there. So I think actually having very specific data around very specific practices, whilst it's not comfortable, I think it absolutely does get action.
Good, yeah. But by all means, share my paper
I will do.
with the clinical directors.
Thank you.
Okay.
Are there any other questions for Rebecca? No. Thank you very much for the report. It's really good to see what's happening across in the West, and we look forward to seeing you again next time.
That's great. Thank you very much.
Thanks, Rebecca.
Thank you. Bye-bye.
Moving seamlessly onto prescribing.
Ooh, I didn't even mute. Okay. Yeah, thanks, Doris. So yeah, prescribing report. I've done a fairly light report this time, without a major theme. I was thinking perhaps next time I might focus on electronic prescribing, which is of interest, and Norfolk and Waveney isn't doing quite as well as it should, and it is something that will help us certainly post EU exit in terms of making medicine supply more continuous and sort of monthly rather than in larger quantities. So things we're been up to recently. We prescribing leads. We managed to get Dr. Mark Abrahams, pain consultant from Addenbrooke's, to do a 1-hour presentation and Q&A with our GPs on chronic pain, and he did a very helpful a critique of New Nice guidance, which went down very well. Anybody who wants the recording or the slides to share, please contact myself, and we can get that to you. He's very on message with not using high dose opiates in chronic pain, because that is the direction of travel. They rarely have a place. They do have a place in the odd patient, but that message came loud and clear, and the more people we can get that message to, the better, in terms of changing the way that chronic pain is treated. Any non-clinicians, I would encourage you to ask for a copy of the presentation, because it was all very clear, and it was in fairly simple terms explaining the issues with chronic pain treatments. Looking at our cost pressures, I sort of highlighted again, these keep going up every month, which is quite alarming. Sertraline shortage has caused a £1.7 million, I mean, as an example, and a volume rise since COVID has happened. So that's a bit of a worry. And DOACs are going up because of movement away from warfarin, etc. Freestyle Libre has suddenly appeared as a significant cost pressure, or some of that is funded by NHS England. Dependence forming medicines, I know Hein wanted to reflect on the risk register. So high dose opiates, the actual indicator for this is being updated. So this our 33rd nationally hasn't changed for a few months, because we're waiting for an update on the indicator, because of Faculty of Pain Medicine has changed the opiate equivalents and so they need to be recalculated, and it shouldn't affect us in terms of our position, but it'll be interesting to see when it does come out. Gabapentinoids, we have improved. When the risk went on to the risk register, I think we were 14th nationally, we're now 28th, improving from 27th the previous month. So I thought it appropriate to consider taking that off the risk register. The one that is still on there, which is important, is the hypnotics, because that is the one that's fairly resistant to effort to reduce it, because it's not that easy to get patients off them once they're on them, and we have quite a few patients on hypnotics. So that one does need to remain. Perhaps we could, when I've finished, discuss whether gabapentinoid should remain. I would say it could be retired for the time being, but come back on if things seem to be going adrift. Antibiotics, I had a slight focus on antibiotics because one of our indicators has gone above our national target. 10% of antibiotics there should be no more than 10% of all antibiotics should be broad spectrum antibiotics, because they're the ones that increase the risk of resistance, and resistance to antibiotics is a worldwide issue, and it indicates that perhaps the formulary isn't being adhered to. And the formulary is mostly recommended by NICE with local input from microbiologists if there is some local variation. So we're slightly concerned that our 5 highest prescribers they all happen to be dispensing practices, and 3 of them aren't signed up to the PQS. We have written to them, encouraged them to sign up to the PQS, because when they do that, they can be funded to do an antibiotic audit. So they'll be paid to do an antibiotic audit, an action plan, and that would be quite good for their CQC visit. So that would be a good thing for them, and they would get some funding. So why wouldn't they want to do it? But we'll keep reminding them and asking them to engage with that. Certainly the PCN that is causing us the most worry in terms of antibiotics is Swaffham and Downham. So hence suggesting that I get involved in the local delivery group in the West, just to keep highlighting the fact of their performance on some of these indicators, certainly antibiotics and DFMs. So that was any questions? Happy to take questions or discuss the gabapentinoids.
Tony, you were first up.
Quick off the mark. Michael, thank you for your presentation. Michael, when you work out the costs of drugs and you compare warfarin to its new equivalent, which is better and safer, do you take into account the number of blood tests that have to be taken with warfarin and
Yes.
the cost involved in that? So you're actually costing like for like?
Yes, there's an interesting draft guidance from NICE, which is floating around at the moment, which I discussed at governing body recently, and they're suggesting that DOACs are more cost effective than, so these are the new anticoagulants, than warfarin, but their whole costing model is fundamentally flawed, because they haven't taken into account the actual cost of the DOAC to the health economy, because they are fixated on using list price as opposed to procurement price, and that has received much national criticism. So when you do factor in those other costs and take into account the procurement price, warfarin, if somebody's doing well on warfarin, they're better off staying on warfarin, and it's more cost effective. It's quite a complicated arena, but so I won't dwell on it. But there's varying opinion on it, but most people would say that people doing well on warfarin should stay on warfarin, because provided it's safe for them to engage with blood tests.
Thank you.
Okay.
Hein?
Michael, thanks. Also touching on this risk PC9 in the risk register. I know it's early days for your new steering group, but linking back to the discussion we just had on West Norfolk, trying to assess what is the best audience you can get, whether it's one-on-one clinical directors or LDGs, it would be good in several months' time, when you've had a chance to have a number of engagements with the steering group, whether you feel this is getting you the mileage you're looking for, or if not, to report back to this committee and just see if there's alternatives to get you where you need to go. So.
Yeah, I'm happy to report back on engagement with West Norfolk, particularly. Yeah, I mean, certainly we'll keep the DFMs as a standing agenda item, dependence forming medicines, sorry, and antibiotics. So, and I will perhaps in the next month's report, just as I've done with antibiotics, list some practices of concern so that it's out in the open.
Just the sense between the lines over a number of meetings is that sometimes you need individual practices or at PCN level clinical directors see them in the eye to really get progress.
I think it helps, yes.
Thanks, Michael.
Tracy, did you want to come in?
Yeah, it's in respect of the DFMs, Michael. I'm just wondering, often we know that the three come in a combination, so I'm sure that we are cross-referencing particular practices where an issue might be with one, but actually with two or three of them, because often it's the combination, the cocktail that causes the most problems from my own clinical experience. So just a question in respect of that. In regards of the hypnotics, I personally, from my own prescribing practice, the ask from patients during the pandemic, not sleeping, anxiety, there is an increased ask. So have we noticed the cases, you know, people asking, the instance has gone up during the time of the pandemic, and looking at previous trends in that regard for the system? And I think you're asking about the gabapentoids. I mean, I think yes, let's keep monitoring. I think I'm aware of some recent kind of overdose incidences that we've had, and I do think quite a lot of the gabapentoids are initiated in primary care. So I think it's personally, it's something we should keep on our, you know, on our list.
Okay, yeah, I mean, certainly, I mean, as I mentioned, sertraline, which is NICE suggests as first line in anxiety, although technically it's unlicensed, so patients should have patient consent to prescribe it. As the most cost effective, it's no longer the most cost effective, so our recommendation is use NASSRI instead, and don't start patients on hypnotics because they rapidly stop working and you just get an addicted patient, which is a bad idea for everybody and not that effective, to be honest. Increased risk of accidents and increased risk of death from accidents, presumably.
Any other questions for Michael? John?
I suppose following on a bit from both of those, Michael, conscious that you often report on these same areas, and clearly there's a lot of work to try and support better prescribing in these areas, and it sounds like there are areas of concern for patient safety and broader public health in terms of the antibiotics. So what more can we do to support you, I suppose? Is there any more that we could do as a committee?
That is a very good question, and I could throw it back. And what do you think we can do? I mean, in the pre-COVID days, I was going around as many LDGs and primary care commissioning committees to air these issues in public, because I think that's important that it becomes widely known what the issues are, and to get some traction for change, and put them in the prescribing quality scheme, which we had to pause for a little while. We've now got that back on track, so that there are some drivers in the system, and we're writing to practices who are at the top and encouraging them to do, say in antibiotics, do the audit, and we'll pay them to do the audit, and we'll be engaging with practices once we get our DFM working group in a more delivery mode. Practices at the top, and as Tracy says, it is important that perhaps we focus more on the practices that have the triple whammy of the trinity of DFMs, because that's the most highest risk. I don't know. I mean, I'm happy to be advised, but I mean, things aren't. We're not doing practice visits at the moment either, so that's something that we could hopefully restart middle of next year and get some more traction in these areas. It is quite a difficult environment to work in at the moment.
I'm conscious of clearly the pressures on primary care, and no doubt that's part of the context in which practices maybe aren't able to do the work that they
Indeed.
And otherwise, having said that, some practices are an awful lot better than others. So
yes,
so it's not that there's wide variation. Something simple. I don't know if it would help if, sorry, Doris, if whether Doris was to write as chair of this committee to express the concern of the committee to some of the practices and request for more information as to what they're doing. It just offers you broader support, I suppose. But the thing might not make a difference. But it's, say, conscious that we often talk about the same sorts of things, and it's how can we move it to a different place, I suppose.
I'd be happy to help draft a letter if that's deemed appropriate. It would certainly using people with special badges, CQC and chairs of committees is potentially useful, just to highlight that the issue has been escalated in some way. Yeah.
Sadie, did you want to come in?
I was just going to add that whilst we don't, obviously the primary care committee papers are reported in public, they're available on our website. We weren't confident that practices necessarily knew what was being discussed or proactively went and had a look. So we have started including the public papers in the practice newsletter that goes out so that practices are aware of what's reported in public, and particularly thinking about the prescribing paper. So that has only been a recent thing that we've started to do. So I don't know if that will also help in being able to refer to the fact that this is reported in public, and practices have the link now to go and have a look at what you said.
Yeah, I'm happy to sign a letter. I'm not offering to draft it or get it wrong, but actually I think it's also about being open. It's being open with practices to go, these papers are available in the public domain, and occasionally your practice name might appear, so that we're not doing things behind people's backs, which would not be helpful. So I personally don't have a problem with it. Where I can be of use, then you can put something in front of me. I will read it before I sign it. But just on the on the training you did, I think it would be useful just to send it to people on the committee, just because I know the minute I come off this call, I will get distracted and I will forget to send you an email, and I'll be in the same position. So instead of you getting 20 emails, I think it would be helpful just to send it out and we can peruse at our leisure. I'm sure it'll be very good bedtime listening.
Okay. Are
there any other questions from Michael? No, thank you all very much. On to the last item under any other business, we did receive a question from a member of the public, but because it doesn't actually relate to anything on the agenda items, I have asked the officers to respond directly to the person. But I would encourage the members of the public, if they want to ask questions in relation to agenda items, please do get in touch, because it's always good to hear from you all. And are there any other businesses from anybody else? No.